Good afternoon, everyone. Today's clinical meet is regarding dengue. So, dengue, there's nothing unusual about dengue. We see every year from July, August, September till January. So, the same thrombocytopenia, the same fever for 5 to 7 days, and same thrombocytopenia, and usually no bleeding manifestations. This is what dengue is all about. But today I chose this topic specifically because last year we had a epidemic of very severe dengue, and the mortality was quite high compared to the previous years from 2017 to 2021. So if we have a look at the cases to the previous years, the patients were like the patients requiring ICU were very minimal, and most of them they were managed in ward and they were discharged. So the previous year we noticed something which was very unusual. Last year around 5 to 10% of the admissions roughly, I don't have the exact data though. So we had a lot of patients who were occupying ICU for a very long time, and they had few manifestations which were like reported as case reports only, like what we have seen as case reports previously long back. So we saw all sort of manifestations in dengue the past year. So that's why I thought I'll discuss this case today in this clinical meet. So patient profile, she was a 50-year-old female from Kotagiri, Ooty, and she was a housewife by occupation, and she was admitted close to 20 days in our hospital, and most of the stay was in ICU and a few days in ward. So this particular patient, before coming to sorry, I think 20 instead of 5 date. So this particular patient, she was initially treated in Ooty with history of fever for 7 days. She had chills and rigors, the usual myalgia, headache, bleeding gums. So in view of bleeding manifestation, she was admitted in local hospital in Ooty, where she worsened very rapidly, and she was in ICU. She received multiple transfusions in that hospital, and she was started on antibiotics. Empirically, she was started on piperacillin tazobactam, and she was sent here in view of rapid worsening. So this particular patient, she had dark colored stools, rashes, so like possible melena, rashes, and she was evaluated outside and was found to have severe significant thrombocytopenia. At the time of admission, she had a platelet count of around 15,000, roughly around 10 to 15,000, which was fluctuating even with transfusion, and she had jaundice at presentation. She was transfused outside. She was transfused 4 units of platelets and 2 units of PRBC in view of bleeding manifestations and thrombocytopenia. And this particular patient had also had recurrent hypoglycemic events. So she is a diabetic and hypertensive, and at presentation she was on NRBM and was tachypnic. There was hypoxia, there was tachypnea, and she was in altered sensorium. She was stuporous, and she was we waited for a day because the platelets were very low and the sensorium was borderline. We didn't want to intubate this patient, so waited for a day, and so sensorium slowly improved in a day. So this particular patient was not intubated. Sensorium improved in a couple of days, and we kept her on NAV in ICU, and patient required multiple transfusions during here hospitalization also. So this particular patient, we did the routine investigations including IgM scrub, IgM lepto, NS1 negative, NS1 IgM dengue, everything, malarial parasite, blood cultures, everything was done. And after blood culture, she was started empirically on she was on piperacillin tazobactam. Here it was escalated, and she was put on doxycycline also, because most of tropical illness, they present with a similar history and clinical presentation, and one among them is leptospirosis, and the other one is scrub typhus. Both can present with a similar history, so we put her empirically on doxy also. So then this patient underwent multiple platelet transfusions even here in our hospital, and the platelet count slowly improved. Every day routine investigations, dengue, NS1, IgM, malarial parasite, everything was negative. She had a deteriorating neurological status. Then it slowly improved. CT brain was done, which showed no significant abnormality. We suspected bleed, but there was no bleed. And further workup was done, which included scrub, rickettsial panel. Everything was negative. And so we did a imaging contrast, CT of abdomen and thorax. So sometimes in dengue, the patients present with fever, thrombocytopenia, and despite multiple multiple times, even if we repeat NS1 or IgM, most of the time it turns out to be negative, but clinically they will have a presentation. These patients may have a polyserositis and edematous gallbladder wall, and mild transaminitis, some amount of jaundice. Sometimes clinically we'll have to make a diagnosis, and if we don't have a clear-cut diagnosis, we still we continue piperacillin and tazobactam and or ceftriaxone and doxycycline. So this particular patient, clinically she was fitting in like dengue, so we continue the empirical antibiotics, and she was treated with supportive measures including IV fluids and NIV. So she gradually improved in ICU, and fever settled, thrombocytopenia started improving. The patient's platelet count started going above 1 lakh. So then she was shifted out of ward. So when she had presentation, she had shock, which improved. Renal parameters were high, which started improving, and she was clinically much better. So sensorium also improved, jaundice improved, shock improved, everything improved. She was shifted to the ward. So till this, it's a routine case of dengue. What we see as a severe dengue. They present with all these manifestations, and once the cytopenia starts settling, when they start redistributing the third space fluids, they get better. So, but what happened to this patient was, she was in the ward, she was doing well, slowly improving, and we were mobilizing her. All of a sudden, one fine day, early in the morning, she started developing high-grade fever. High-grade fever, which was like 103, 104, and high respiratory rate was also high, tachypneic. She was hypoxic. Sensorium started worsening also. So, and repeat blood investigation showed that is some further worsening of cytopenias. That is, she had anemia, some amount of leukopenia and thrombocytopenia, which started gradually improving after the ICU stay. And once she came to ward, again it started worsening. Hemoglobin started dropping, and her platelets went down from above 1 lakh to around 15,000 slowly, and liver enzymes, which were settling down, started going up. She started having coagulopathy eventually. So we were like thinking in the terms of secondary infection, catheter-related infection, or urinary tract infection. There is catheter-related urinary tract infection, or that is hospital-acquired pneumonia. We were thinking on that line. And repeat CT was also done, contrast CT thorax and abdomen, because her creat was normal. Contrast CT was done. Contrast CT was not showing any particular foci. There was no lung involvement or future suggestive of pyelonephritis. So, and sensorium started worsening, and she was shifted to ICU, and hypoxia worsened, tachypnea. She didn't go into shock though, so everything started worsening. So we thought possibly this could be a secondary HLH, secondary to dengue. HLH secondary to dengue is very, very rare, and we have seen only very few case reports. So previously we have seen a couple of patients who presented to this hospital, like one patient from Rameshwaram. He was shifted all the way from Rameshwaram to Madurai, and then from Madurai he was shifted to Royal Care ICU, and eventually he succumbed within 3 to 4 days. So he was unable to do anything because he was profusely bleeding and severe cytopenias with cytokine storm, that is shock, liver dysfunction, severe ARDS. So ultimately we lost the patient. So we thought, okay, this could be evolving HLH. So we started workup for HLH in view of the counts which are gradually dropping down, new onset fever and worsening of sensorium and new organ dysfunction. So investigations were done, which showed initially the ferritin was around thousands and started it going up, and it went up to 7,500. And fibrinogen, which was previously normal, started coming down, and triglycerides were also, fasting triglycerides were also high. So in this particular patient, we kept a differential of secondary HLH. So bone marrow was also done on that day because she was rapidly worsening. So H score was scoring for HLH was done, which was around 307 points, which was a very high score, and there was more than 99% probability of hemophagocytic syndrome. So then we decided whether to start her on IVIG versus steroids. She had usually we prefer to start with IVIG and steroids both. We start both IVIG and steroids, but this patient was had severe financial constraints, and they were unable to continue the treatment in ICU. So we thought, okay, this was discussed with the family, and they were not willing for IVIG. So we started around dexamethasone 10 milligram per meter square. So eventually with dexamethasone, she became afebrile, and cytopenias also started recovering. Ferritin, triglycerides were quite high, and liver dysfunction was also there, and the ferritin was around 7,500. And her LDH was also high, hemoglobin was falling rapidly. So all those things settled down. Slowly it started settling down. Ferritin started coming down below 1,000, and her cytopenias, including thrombocytopenia, total count, and platelets, everything started improving. So her respiratory requirements also went down, and she started improving. Still, the family was told that if she is in case of any worsening, there was no other way other than IVIG. So, but fortunately for us, she improved with steroids alone, dexamethasone alone, and steroids were continued slowly till clinical improvement. It was slowly tapered and stopped. So the final diagnosis in this case is acute febrile illness, dengue, and secondary. And other thing was when the second time when she went to ICU, we repeated everything, including NS1, IgM, everything was repeated, and everything, the NS1 and IgM were both positive. So finally she recovered, and she has been sent home, and she has come back for 2 reviews. She is doing well. So the reason we're discussing HLH today is the last 1 year we have had very many number of patients with HLH secondary to dengue, and one patient had some other acute febrile illness, and he was treated outside before, and he came with HLH here. He was treated. I was admitted under Dr. Arul Selvan, and one more patient was admitted under Dr. Arun. He has scrub typhus, documented scrub typhus, started developing secondary HLH, and he was also successfully treated with IVIG and steroids. So the last year we have seen quite a number of, at least I don't have the exact numbers though, but at least it would be more than 10 patients. So what is the criteria for HLH? So HLH, we usually use a traditional HLH 2004 criteria, which needs at least 5 of the following, which is fever more than 38.5, which was present in our case, splenomegaly, our patient had both hepatomegaly and splenomegaly, and cytopenias affecting at least 2 cell lineages, hemoglobin less than 9, platelets less than 1 lakh, and absolute neutrophil count less than 1,000. Our patient had pancytopenia and hypertriglyceridemia, fasting triglycerides more than 265, and fibrinogen less than 150, and ferritin more than 500. At some point of time, sometimes we may not have all these things in a patient with HLH. So eventually their fibrinogen level will go down slowly, and hypertriglyceridemia also will. Sometimes it may be diagnosed, that is, it may be detected later. Initial investigations will show a normal fasting triglycerides. Sometimes it may go up. So, and the other criteria are hemophagocytis seen on tissue biopsy, either bone marrow, spleen, lymph node, or liver biopsy, and low or absent NK cell activity, which we are unable to do that, and soluble CD2. The last 2 criteria which cannot be done here because it is we have to either send it somewhere or outsource it, and by the time it comes it takes a lot of time. So we usually nowhere it is done low or absent NK cell activity and soluble CD5 receptor. So this is a modified HLH criteria which requires at least 3 of the following: fever, splenomegaly, cytopenia, hepatitis, and at least 1 of the following: ferritin elevation or hemophagocytis and tissue biopsy. So other supportive features are the 3 listed: hypertriglyceridemia, hyperbilirubinemia, and hyponatremia. So in our patient, the patient had a fever, organomegaly, cytopenias, ferritin, high ferritin, and it was documented on bone marrow also. I think we had around 6 criteria, including low fibrinogen and hypertriglyceridemia. And clinically also it was a case of HLH. So when to suspect HLH in any patient? So is we cannot expect thrombocytopenia, leukopenia, and hemoglobin drop, and all the criteria to be fulfilled, because sometimes initially we may have a partially fulfilled criteria, and later on all the criteria may be fulfilled. So we cannot wait, because this particular condition has a very high mortality, and if it is not treated, even with the adequate treatment, the mortality is very high. So when we don't treat it, the thing is, if we delay the treatment, the patient is going to perish, is going to die. So any patient with somebody was presenting with say for example any autoimmune disease patient, patient of SLE or some autoimmune disease, presenting to hospital with fever, CNS symptoms, cytopenias, and rapidly rising ferritin. So sometimes the patients may have CNS symptoms, hepatitis, coagulopathy, and rising ferritin, which will be quite unexplained. And sometimes in ICU patients, especially in ICU patients who are already hematology patients and connective tissue disease patients, staying in ICU for some other reason, suddenly worsening of hypotension and no response to antibiotics and rising ferritin, rapid worsening, all these things, in all these conditions we have to suspect HLH. So primary versus secondary. What we are seeing here, what we have seen in the last year, everything is a secondary HLH. No, none is a primary HLH. Primary HLH is usually diagnosed during in pediatric patients, and it is a heterologous autosomal recessive disorder that is often seen in parental consanguinity. I have never seen any case of primary HLH. And there are 5 genetic subtypes, 1, 2, 3, 4, 5, caused by genetic mutations have been identified, and they have genetic studies also for this. So FHL results from uncontrolled proliferation of overactivated T lymphocytes and macrophages, as well as overproduction of inflammatory cytokines and dysregulation. This particular disease is very rapidly progressive, and they tend to have a course of repeated infections. So it is based on the clinical findings and genetic testing. Because the disease may develop in utero, it can be potentially present at birth, and HLH patients are prone to various infections. This is regarding primary. So we usually don't come across primary HLH. What we come across is a secondary HLH, and it is usually seen in adults, and it is often secondary to autoimmune diseases, cancer, or infections, in contrast to familial HLH. So usual causes infections like dengue, scrub typhus, and autoimmune etiology like adult onset Still's diseases. In those cases, we call it like macrophage activation syndrome and SLE. So this is the treatment. This is quite complicated. This is for primary HLH 2004 protocol, HLH 94 protocol. So it involves dexamethasone, etoposide, cyclosporin, and methotrexate. So this thing we don't use this. There is no need for us to use this particular issue. So here is a abstract from American AHA guidelines regarding HLH. So here it is primary versus secondary HLH. The secondary HLH is most of the times infection occurred. It can be Epstein-Barr virus or other infection by other viruses, and leishmaniasis, which we usually don't see. And what we commonly see here is dengue, and one patient of scrub typhus we had in our ICU. He was admitted in ICU, and that patient was also treated successfully. And there is malignancy associated HLH in patients with lymphoma, autoimmune disease related HLH, drug induced HLH with checkpoint inhibitors. And generally in secondary HLH, what we treat here is we use dexamethasone and IVIG. So a combination of dexamethasone and IVIG is used. We usually don't use etoposide and methotrexate and all those things. So in secondary HLH, that is secondary to infection, we use IVIG and steroids. So the last 1 year we had around we successfully treated around 3 or 4 patients. 5 patients. One was this patient. The other one was under Arun, Dr. Arun. He was a case of scrub typhus with HLH, and one patient was admitted on Dr. Arul Selvan. That patient was admitted in ward. He had neurological manifestations, severe cytopenias, and he was not very sick. He was started on IVIG, and slowly he improved in ward itself, IVIG and DEXA, and he presented with altered sensorium, thrombocytopenia, He was a 16-year-old boy who improved very rapidly, and he is under follow-up. And one more patient was admitted under Dr. Chandrasekhar in ward. It was like dengue. Then he started having worsening, persistent fever, cytopenias, and Dr. Madheshwaran, Manish, and Dr. Chandrasekhar, and everyone, we were all treating him, and they all improved. And in ICU, we had these two patients were treated. One was this patient, the other one was under Dr. Arun. So both these patients were treated successfully. We lost a couple of patients also, like one patient who was from Rameshwaram. It was very, when he presented here, was profusely bleeding with severe ARDS, multi-organ dysfunction, and another one patient also severe dengue, eventually developed HLH. Despite steroids and IVIG, he also died. So the thing is, in dengue, we have not seen so much like sick patients getting admitted and having a very drastic course. But particularly last year, we had, especially in ICU, we had a lot of patients who were very sick, and these patients all, most of them, they had HLH. So, and long back, I think one patient, and Dr. Karthikeyan, was also having same HLH. He was treated with IVIG and he improved. So we started seeing a lot of patients of secondary HLH in patients with dengue recently. So whenever a dengue patient who is supposed to recover the particular period of time is not recovering and is very rapidly worsening, we'll have to think about a diagnosis of HLH. Not just dengue, any secondary, any infective etiology for that matter. Sir?
The 10 cases that you mentioned.
Not, I don't have the exact list. I just it is from my.
Is not responding to steroids or IVIG. Probably Adam TS mutation.
So Adam TS is usually TTP for TTP, thrombotic thrombocytopenic purpura. That is a different.
They overlap.
Secondary HLH, that doesn't happen usually. HUS and TTP, they overlap.
But clinical course will be almost the same.
Clinical course, sir, in TTP, they don't have they don't have coagulopathy. Usually, they don't have coagulopathy, and predominantly it is thrombocytopenia with hemoglobin drop. Total count is usually not affected in TTP. So Adam TS13, in secondary HLH, when we have a clear-cut diagnosis of previous infection and secondary HLH, I won't do.
What is unusual when they are not responding to?
HLH per se is a very fatal condition, and not a lot of them make it out. And sorry, forgot to mention, we had a case of tuberculosis with HLH also. In the last 1 month, we had one patient of tuberculosis who had HLH, and he also didn't make it. Documented HLH. There were case reports of tuberculosis, disseminated tuberculosis with HLH. This particular patient presented with fever, and EBUS was done, and it was positive for AFB, and eventually initially he started improving, then he started worsening rapidly. Then it was elderly male, so it was decided not to escalate further. The family was discussed, and it was decided not to escalate further for that particular patient. The thing is, it can present in any disease, any secondary to any infection. So,
well done, actually. I think some of the cases we were also involved in it.
Yes, sir. That was what I'm saying. Most of the cases, the diagnosis was done in ICU, except only one or two patients. One was in ward, and two patients were in ward. Most of the cases, it was admitted in ICU, and there only we did a bone marrow, and most treatment which was done, most of them this was in ICU. This particular patient was also in ICU. So
a couple of things I just want to mention is one, I think this being a large case series, we should think of
publishing.
One. Two, I think for everyone, I think the high index of suspicion is important.
So,
So you suspect and you make the diagnosis at appropriate time. I think the outcomes will be better.
better.
So many a times I think they are not diagnosed in
time. So Dr. Kumar sir, he knows very well. Last year we had a lot of sick dengue referral from outside, and like last year the mortality was quite high, and a lot of times we had a couple of times these patients had documented HLH. So previously, in the previous years, I have not come across so much HLH. As a matter of fact, only once I have seen one patient of dengue, recovered from Parani. She was discharged. She went home again, fever, and started worsening. Bone marrow was done, HLH. So, but they were not affordable. They were unable to continue the treatment here. They left.
We have two announcements. One is we have the ICU update next Sunday. And Saturday we have